Welcome, everyone. I am Allison Drew. I'm the program coordinator for the Iowa Regional Autism Assistance Program. Welcome to our Autism Basics Webinar Series featuring Dr. Kelly Pelzel. This session is on therapy options. And just a friendly reminder that certificates of attendance and foster parent training credit are available for the live session only. And now I am happy to introduce Dr. Pelzel. Dr. Kelly Pelzel is a licensed psychologist and a clinical assistant professor working in the University of Iowa Stead Family Children's Hospital Child and Adolescent Psychiatry Division. She received her BA from the University of Northern Iowa. Dr. Pelzel received her PhD from the University of Utah. She completed her predoctoral psychology internship at Primary Children's Hospital in Salt Lake City. Dr. Pelzel completed a leadership education in neurodevelopmental and related disabilities postdoctoral fellowship at the University of Iowa Stead Family Children's Hospital Center for Disabilities and Development. She provides assessment and treatment services. Dr. Pelzel also serves as the clinical coordinator for the University of Iowa Stead Family Children's Hospital Autism Center and the psychology consultant for Iowa's Regional Autism Assistance Program. As we go through the session, questions can be typed into the Q&A box, and Dr. Pelzel will respond to them at the end of the session as time allows. So now I'll turn it over to Dr. Kelly Pelzel.
Thanks, Allison, for that introduction, and welcome back if you were here last week. This is a part of a 4-part webinar series. So last week we talked about what is autism, and today we're going to talk a little bit about therapy options for autistic individuals. And then we'll have a couple more weeks here where we'll talk about treating dangerous behaviors and school programming as well. So look for that over the next couple of weeks. So I'm going to go ahead and stop my video now. I'll turn it back on at the end when we do some questions and answers. And again, if you have anything as I'm talking along, for sure, just type it into the Q&A, and then Allison and I will address those at the end. So just to kind of give you a sense of where we're going, first, I'm going to give you some general thoughts on intervention. And then we'll talk about specific evidence-based therapies, how they come up with those determinations of what is evidence-based, and then what are the therapies that are considered pretty much by all organizations as evidence-based therapies. And third, we'll talk about what's common. What are people accessing? Before we start, I just want to say a couple things about my background, so you kind of know where I'm coming from. So I'm a clinical psychologist. That's training where for your PhD, you oftentimes do a lot of clinical work, but you also do a lot of research and learning about research methods and statistics, and being a good consumer of data and all these things. And so going through that model as a clinical psychologist in what they call a Boulder model program, I think a lot about what is the evidence for different practices, different interventions, those sorts of things. So I think there's even a question last week where I was just like, I don't think we have good enough data to like answer that question. We could get some data, but that's kind of how my mind thinks about things. I think it goes back to when I was young and went through that training that kind of got ingrained in me. That said, there are places that are kind of still frontiers where we don't have a lot of data. And I'm specifically thinking of adulthood for individuals with autism. Most of the research that has been done on what works has been completed with children and adolescents. There just isn't a whole lot out there in terms of adults with autism and having that as the intervention population people are doing studies on. or sample that people are doing studies on. So a lot of what I'm going to share today in terms of evidence-based therapies is going to be focused more on therapies and interventions available for youth, not for older adolescents and adults, because there's just less out there on what we actually know. And that's a big area of research right now, as we've realized that gap. People are kind of trying to catch up, but we're not there in terms of what we know at that age versus what we know with very young kids and up into elementary school and beyond. So okay, so just some general thoughts on interventions. First, when we do an intervention, it is typically done with some sort of goal and treatment goal in mind. So what do people want to work on? And that can be highly individualized. Last week, we talked a lot about the wide variety of presentations of autism spectrum disorder. And with that variable presentation, there can be a lot of difference in what those individual needs are, what people want to be focusing on, and where that child's at with those different skills and deficits. So these are just a few, areas that oftentimes people target with interventions. But for each family, it's going to look very specific to their child and what those needs are. So communication, social functioning, and play skills, those are big areas. If we think about the criteria for autism spectrum disorder, that makes sense because those are areas that are typically deficits. Improving adaptive functioning. So more like daily life skills and around home, around the community, things like that. Academic functioning, certainly, learning in the classroom. Decreasing challenging behaviors, and particularly behaviors that are dangerous behaviors, can be an area. And addressing those comorbid conditions as well. So things like anxiety, depression, or like more on the medical side, making sure that we have someone who's working in the family if there's concerns about seizures or GI problems, those sorts of things. When a provider is writing intervention goals, we want those to be written collaboratively with patients and with their families. So that should not be like the therapist on their own writing those goals out. That really should be a discussion that takes into account the child's needs, your values as a family, what's important to you, and with some way to measure what's happening with that over time, so that we can assess progress over time and have a way to share that with the patient and their family over time. And when we do that, oftentimes we are thinking about kind of that long-term outcome we're going toward, and then particularly if they're doing a time-limited intervention, what are some short-term treatment goals that we could put together that are going to scaffold toward that bigger picture? So an example would be, expressive communication. Many parents are wanting, in terms of a long-term outcome, for their child to be able to verbally express themselves, to use words to express themselves. But sometimes in interventions, we think about those kind of pieces that are, again, going to lead to or kind of scaffold towards that longer term outcome. So, if I'm working with a young child and that's the long-term picture, we might work on things like pointing and gesturing as short-term treatment goals that are going to provide that scaffolding towards eventual verbal communication. Like I said, there's not a whole lot out there on adults, but these are some goal areas that oftentimes come up for adults. So again, some of that social stuff still, social functioning, understanding social cues, living independently, friendships, romantic relationships, having purposeful daytime activities available, employment or otherwise, managing day-to-day stressors, and managing some of that psychiatric symptomology as well. So when I think about like why this emphasis on evidence-based, like I said, there's a little bit of my training, but I also get real practical with it. And when I think about autism, there are so many therapies out there for autistic individuals. And some of these therapies, even ones that have like manuals and like step-by-step instructions of kind of what to do, don't have a lot of research showing that they actually work. And when I think about people, their time that they can put into things and financially what they can put into things, those are limited, and so I want to get that resource towards things that I expect to work, and being interested in science and believing in that as a system for knowing what works. That's what I'm gonna recommend to people and use myself as a provider when I'm providing treatment. The other things to keep in mind, though, are that some of the time there's like multiple therapies that could fit the bill for the kind of goal that the family has. And in that case too, you want to really think about like what the fit is for the patient and their family, like what their values are, how they like to work with their child, how they like a provider to work with their child. And if, there's a couple of evidence-based things available and they seem to be equally good in terms of the research, we also want to be thinking about that fit. And I guess I said are available because that's the catch as well, is that not all interventions are available in all places. So oftentimes, especially in rural areas, we're kind of still limited by that in terms of what's available. I have a link here. I'm not going to show this video, but I would encourage you to take a look at this website as a whole. I think I have it later in the presentation as well. Interactingwithautism.com. Some of the videos are fairly dated now. I don't think the information has changed so dramatically that they're not useful. What I like about these videos is it really shows nice pictures of what different treatments, what different therapies look like. You can get really a good feel for how that therapy looks and feels. So take a look at that. This is just a researcher talking about this idea of oftentimes there's choices, and sometimes we wish there were more choices in some areas of the state and the country. Okay, when people, I'm going to turn now and talk about evidence-based interventions. When people talk about that, they kind of talk about things at two different levels, I guess, is a way to say it. But one is talking about like what they would call a comprehensive treatment model. So a big program that is fairly time intensive and very covering like lots of different therapy goals, and really is meant to have a big impact on perhaps even the core features of autism spectrum disorder. So examples of this would be like kind of name brand things like Early Start Denver model or LEAP or the TEACH program. These are all programs where they are working many hours a week with kids. They have kind of a theoretical orientation, and things are kind of conceptually organized within that theory. And they're working on, like I said, multiple outcomes with these techniques that are kind of all tied together. These are the kinds of treatment programs where it's not like you just go to, a lecture on it and then you can give it as a provider. It oftentimes requires a lot of training and perhaps even a certification process in order to even offer it as a therapy or a service. So These are kind of the bigger ones, and they oftentimes start when kids are really young. Like I said, they're time intensive, meaning maybe 25 hours a week or more. There's a pretty low student to teacher ratio. So there's lots of opportunities for direct teaching and one-on-one work. There's a family component where the provider is not just working directly with the child, but also teaching and sometimes coaching the parent on what to do. Oftentimes, especially as the child is becoming more skilled, there's involvement of typically developing peers to practice different skills. There's certainly, and this should be with any kind of intervention, but a way to measure progress and adjust the techniques or the strategies that are being used based on what's going on with the progress. There's usually really high structure. So things like routines, visual schedules, those kinds of things when a child's enrolled in a program like this. And then this is always the tricky one, but hopefully there's also strategies in place that help promote generalization so that the child is able to perform skills, not just there in the context of therapy or the intervention office, clinic, but out in real world on the playground, those sorts of things as well. That's tricky for any intervention. So you'll oftentimes see a lot of significant gains in session with interventions, and then not as many gains in terms of kind of out there in the real world. So people work on this question of generalization quite often. Okay, so that's comprehensive treatment models. Now, kind of a different way of thinking about evidence-based therapies is to think about focused interventions. So these are more like pieces, and these pieces can be the pieces that make up comprehensive treatment models, or they can just be kind of standalone things that people are doing. So this would be something like a technique like discrete trial training or visual supports or prompting or visual modeling. Again, these things are all like operationally defined. They are meant to target specific outcomes that people are looking to achieve, particularly if they're not being used as part of a comprehensive treatment model, then they tend to occur over a shorter period of time, less intense. And it's really thinking about that individual goal that someone's working on. A lot of these interventions, while we don't have a lot of data in adulthood, we know that they can be used across the lifespan. And like I said, they can be then these building blocks within a comprehensive treatment model. So for example, imitation training. Teaching young kids how to imitate you is a component of Early Start Denver model, which is one of those comprehensive treatment models. But it can also be just a standalone focused intervention that someone does to work on imitation as a skill. So when we think about where to get information on what is evidence-based, whether it's a comprehensive treatment model or a focused intervention, these are the four places that I typically send people. And I send people to multiple websites because everyone defines things just a little bit different. So what they kind of consider like making the cutoff in terms of enough science has been done or not varies just a little bit. So if you look, across these four websites, these four clearinghouses, you can start to get a good feel of like, hey, this kind of intervention is on every single one of these. And I kind of like that to be thinking about those different perspectives. And of course, on the website or in the papers and such, you can get information on like how they made that cut line. We're going to look at that specifically with this National Clearinghouse one here listed at the bottom. So American Academy of Pediatrics, I think the revised guidelines last were published, sorry for that typo, in 2020. So they're relatively up to date. National Autism Center, not so up to date. They're overdue in getting a new phase out. So phase 3 hopefully will be coming out so that they have more updated information. Association for Science in Autism Treatment. That's kind of a neat website because it's run by parents, but very scientifically minded and very much thinking about the evidence base for treatments. And then lastly, this National Clearinghouse on Autism Evidence and Practice, relatively up to date. So new summary was published in 2020, and they keep things up to date there. And it's out of University of North Carolina. And they have like a real long report you can read, but they also just have like some real short documents you can access as well on their website. If you just want to go like, hey, did this kind of therapy, does it make the cut or not for these folks? The reason I'm using it as an example to kind of show you is because I just want to kind of show you how they come about with these decisions. And I think this one takes a fairly balanced approach to things. So first of all, I just wanted to point out that intervention research has really gone bonkers here in the last decade or so, as you can see, compared to, 20 or 30 years ago. There are many, many more intervention research studies published than ever before. So it will be important. The difference between the dark blue and the light blue is the light blues where they stopped their analysis last time they came up with their publication. And then when they did the revised in 2020, they included all the things from 2012 to 2017, as well as the older stuff as well. But basically, these are studies where a group of people have decided the methodology for the studies was good. And then they kind of agree on that methodology of, yes, we're going to include it if it looks like this. And then they look at all the research articles that have been published for individuals. And again, here you can see that limiter of ages 0 to 22. So they're really just focused on young people in this review. And the interventions can be behavioral, clinical, developmental, educational. They're including all those. And this is the important part. The studies can be either randomized trials or single subject designs. It doesn't have to be a randomized trial or even a group study in order to be included. But yeah, they have these experts who decide like, okay, this one has methodology that's good enough to include it. So in order to make this clearinghouse's list, things have to have multiple studies. So either 2 high quality group designs, experimental group designs, completed by 2 different research labs, or 5 case study designs completed by at least 3 different research labs, or 1 group design and 3 case study designs. So that's where I like how it's a little bit flexible that way, because some people really want to just look at that group design and randomized trials. And when you do that, you end up excluding quite a lot of research, particularly really good research that was done early on. So this is this chart just kind of meant to show that excuse me, the high percentage of research studies that are single case design. So about 83% of the studies that were included, of the 972 they included, were single case design. And as you look at through the years, it's really only recently in that 2012 to 2017 period where people have started to do more group designs and more randomized trials. And there's many reasons for that. We can talk about that more in the question and answers if you're curious. But I'll just kind of move on for here because this is a lot of getting bogged down in some numbers and stuff. Okay. This is just to give you a sense of the different kinds of outcomes that were measured in the studies that they included. So academic things, cognitive skills, communication, social behaviors, play, like there's lots of different areas that were like the targeted outcome for these intervention studies. And in the end, and I know this is really small and I'm not wanting you to like, it's purposely, I don't want you to read through all this, but in the end, basically, they had 28 empirically supported interventions. So 28 therapy approaches that they felt there was enough research to say they're evidence-based. And this is the table that lists all of those. And if you do kind of look down through the names of them, you'll see like a lot of them are behavioral interventions. And if you think about like single subject design, a lot of behavior interventionists use single subject design because so it all kind of holds together that way, that they've been doing research a long time with individuals with autism, and they've published their results, and they were a lot of them were trained in single subject design methodology. So, but there's others in there that have come on more recently, and I think are more open to kind of group design. So an example of that would be like social skills training is one where actually, 15 years ago, there wasn't like a lot of research on social skills. It would not have made this list at that point. And in fact, there were research articles saying like, hey, people who are doing social skills research or social skills groups, can you do some better research so that we can show that they actually work? And people started, gathering data and publishing their results. And now we have good science showing that social skills training works. Another one that has just recently come onto the list is sensory integration. And maybe you can't see this because it is really small, but this is specifically like there's a registered trademark that's tiny, tiny on here, but a specific manualized version of sensory integration. So not all of sensory integration generically is evidence-based, but this particular protocol that the person who got the trademark for sensory integration, their stuff is considered evidence-based. But you can see where just really recently they had enough data to be able to make the list. And compared to some of these other intervention strategies that have been around a long time, there's not nearly as many studies. Okay, so that's enough of that real detailed stuff. When we look across all four of those clearinghouses, so not just the one I was showing, but the other three as well, I'm just going to kind of tell you the therapies that are supported, that everyone agrees across those entities that these are evidence-based things. First is applied behavior analysis, or ABA therapy. And this would include ABA therapy that would target dangerous behaviors, such as functional communication training, where oftentimes you're working on increasing communication skills at the same time you are working on decreasing dangerous behaviors. Naturalistic developmental behavioral interventions, which is kind of a mouthful. I wish they had a better name for this group of interventions. But they're basically interventions that use things from ABA and use things from more developmental approaches, more child-led kind of approaches. So some ones that we have here in Iowa, Early Start Denver model, Project Impact, they fall in this group of interventions. Next is cognitive behavioral therapy and self-management training. So oftentimes this is delivered either in a group or individually, and a lot of times to work on anxiety or depression that can co-occur for some individuals with autism. Social skills training also makes the list everywhere, including peer-based strategies, social stories, scripting, and social skills groups. Language training, this is like working with a speech language pathologist on expressive or receptive language skills. So understanding language, expressing yourself using words. A few additional strategies that are supported by scientific evidence, visual supports and visual schedules. Everyone is in agreement there. Naturalistic teaching strategies. So teaching kind of in the moment, things are happening, rather than like in a contrived, like, hey, let's sit at a desk and drill these things. No, this is more like, more like the picture there of like, let's get out this bucket of toys. And as you're playing, I'm going to be working with you. And modeling, either live, like role playing, or video modeling. So showing a video either of the individual themselves or of another person performing a skill. And then parent training. So again, I had this as a component of most of those comprehensive treatment models. Most programs that didn't have parent training before have it now, because it's just so clear that that's a big piece of it, that we need to include parents. I don't know why it took people so long to figure this out, as part of the intervention, in order to maximize success with it. Okay, now we're on to this group of what they call promising or emerging therapies. So these are therapies that don't quite make the cut in terms of the being on everyone's list as evidence-based, but they're nearly there. So first is the TEACH program. I think I gave that as an example of a comprehensive treatment model. It's out of University of North Carolina as well. And it stands for Treatment Education of Autistic and Related Communication Handicap Children. And it's been around a very long time. And a lot of people actually in Iowa have been trained in TEACH techniques. Now, they don't have it set up as necessarily a comprehensive treatment model in their school or their program, but they're using a lot of those techniques. So a lot of times you'll also hear this referred to as structured teaching, which means like we're not doing like a certified TEACH program here, but we're using a lot of the strategies from that program. Technology-based treatments, so using computers or other electronic devices, again, building in terms of research there. As that technology grows, the research follows. Music therapy, it's getting very close. In fact, I should have probably looked this up before this talk to see kind of where they were at. I don't think it's tipped on like the actual lists, but if you look at the publications, there's starting to be very strong evidence for music therapy. And hopefully that will eventually translate to better reimbursement for it as a therapy as well. And finally, developmental or relationship-based therapies. So things like floor time, play project, that is in this promising or emerging category. Okay, now I wanted to just take a little break from talking here for a sec to show you two different approaches to intervention. So you just get a kind of a feel for the difference. One is TEACH or structured teaching. And the other we're going to look at second is pivotal response training, which is one of those naturalistic developmental behavioral interventions. So you should see some differences here in kind of how they approach, and the targeted goals are different as well, but just in terms of how they approach intervention, I think you can see this through the videos. So we'll start with the TEACH one. And hopefully it plays well enough and you can hear well enough. I know that's always the challenge on webinars, but we'll just give it a little go here.
My name is Alice, and I want to tell you about how I learn. I go to mainstream school. This is where I learn. It has structure, with clear areas where my learning takes place. I like boundaries. There are different parts of the floor where different learning takes place. I also like to learn outdoors. I share my learning space with lots of other children. Sometimes it can get a bit much. My teachers help me when I feel like this. We worked out some ways together, which means I'm able to learn. First, they find a place for me to work, a workstation. My teachers show me my visual timetable. We work together so I can focus on what we're doing. And I can get my reward later. This helps me become independent so I can do my timetable on my own. If I get lost, my teacher uses a check your timetable card. When I know what my teachers want me to do, I go to my workstation, where I can work in my own structured way. With my tasks to do on the left, my workspace in the middle, and my finished work on the right. My teachers help me with my work schedule too.
Okay, I'm going to cut it off there, but that gives you kind of a feel of what teach looks like as an approach. And now we're going to watch a video of pivotal response. And again, this is more a blend of developmental and behavioral approaches.
What page?
This,
What page is it?
page 58.
If you need help, let me know.
Need help?
You do? I did.
We always knew Victoria was a special girl. She could count to 100, at age 2.
But I'm ready for vacation. We were actually completely lost when Victoria was diagnosed with autism. So we found the Yale Medicine Child Study Center online. It seemed like that would be tough on Victoria, but potentially could get some results.
Parenting is hard, but parenting a child with a disability is astronomically harder. And providing parents with strategies that they can use is what empowers me every day. I'm Pam Ventola. I'm a clinical psychologist and an assistant professor at Yale Medicine Child Study Center. In autism, the primary areas of deficit are social interaction skills, language, and communication skills. That's your chair. Victoria is a patient that I've worked with for just over a year now. She's bright, capable little girl, but she wasn't motivated to engage with other people. Do you want to start with stickers or go fish? Let's play go fish. What we offer at Yale Medicine is individualized treatment. Pivotal response treatment is abbreviated PRT. It's a behavioral treatment to support language development and social interaction. You want the rod?
Yes.
Sure. For each child, we develop objectives, so very clearly defined behaviors that we want to improve. I got another green one.
I'll dump the rest.
Victoria's goals when we first started working with her included making eye contact with the person she was speaking to, and also using her language to help her begin to engage in conversations.
What did you get?
I got the bird.
Oh.
A lot of the kids that we work with, Victoria included, love bubbles. And we can use these bubbles to motivate the children to communicate with us. So the child would need to use their words. A lot of bubbles or just one bubble?
A lot.
And then I'd reinforce it by blowing the bubbles.
When Dr. Ventola and Victoria were working together, you could
Okay. So we'll
kind
move
of
on
see
from there. So hopefully that that gives you kind of a sense of differences there where, you know, Teach is thinking a lot about kind of front end antecedent type strategies, ways we can set the child up to do well at the task at hand. PRT is using a lot of prompting and reinforcing, but within activities that kids really enjoy doing. Okay, so PRT probably has a little bit more research evidence, right? Because it made the cut, and Teach has not made the cut. Although there are many components of Teach that are focused strategies or focused interventions, sorry, that that have made the list. So like visual schedules, or as that cute English girl said, visual timetables, right? Are on the list. And so these are all kind of things to weigh. And it is really hard if you have a lot of options, you know, of thinking like, okay, what's going to be really best for my child. There are a few more options out there because of telehealth, because a lot of these interventions, particularly those where we're teaching and coaching parents on what to do translate pretty well to working over video. So you can think about what's available. Hey, do we know generally, does it work? Like, what's the research say? One piece I haven't talked nearly enough about, but you got to think about that relationship with the therapist. So once you actually get into it, like, is this a person that you are enjoying working with, seems to understand you and your child, holds those kind of shared ideas about what's important to be working on? Like, that's a big piece of whether a therapy will work or not. And then you got to be tracking specifically, is this therapy working for my child, regardless of what the research says. So, you know, on an individual level, am I seeing progress? Is the therapist sharing that progress with me on a regular basis? I think this is particularly important if there hasn't been a lot of research or enough research yet, when you're trying to decide if it's working or not. Okay, so this is one website where you can get videos of a lot of different evidence-based strategies, a lot of focused interventions used with autistic children. You do have to give them your email address, but then otherwise it's free to use in terms of a website, and has lots of nice information on it. I mentioned before this interacting with autism. These videos are really beautiful. I think they give a real good sense of the differences between different types of interventions. Okay, so now we're going to talk just a little bit about treatments that don't have a lot of evidence. So gluten and casein-free diets, facilitated communication, and auditory integration training. These are all, you know, fairly popular interventions, but don't have research showing that they work. We never recommend chelation or like very high doses of vitamins. They're not evidence to show that they work, and they can be dangerous as interventions. So these are not recommended. Now, I'm not a medical doctor, I'm a PhD, but I just want to say a few words on medical treatment. So if people are using like medication to target specific symptoms, what we know is that individuals with autism are more sensitive to like side effects and stuff than the average individual. In terms of the research, the best evidence for medication being effective is risperidone for severe disruptive behavior, and methylphenidate for ADHD symptoms. A few other things we try to make sure we have in place is like a medical home to ensure there's some care coordination being happening and family support. I talked about the RAP teams last time. That's a good example of like that family support. And then medical care that's specialized for some of the things that can go along with autism spectrum disorder, like seizures, GI problems, dietary imbalances, sleep problems, those sorts of things. Okay, now we'll talk about things people are using. So what's actually kind of going on out there? So this is a list of community-based services, so outside of school for school-age kids that have autism, either with or without intellectual disability. So overall, you can see kids with intellectual disability tend to access a little more services than those without. Behavioral, like ABA, behavioral modification, is fairly popular, along with cognitive behavioral therapy, social skills training. Those are all some of the more popular ones. In school, and this is a nationwide study, not just for Iowa, you can see here, so in school, most kids with autism and intellectual disability are getting some type of school-based service. And actually, even for kids with autism but not intellectual disability, the majority are as well. Occupational therapy is pretty popular. I'd say less so in Iowa. I'd say it's more rare than what's noted here in terms of kids who are getting like direct OT services in the schools here. Social skills training, very popular. Speech language, direct services with a speech language pathologist, so some speech or language therapy, again, very popular. And then as far as medication, about 2/3 of kids with autism and intellectual disability are on some type of psychiatric medication. And then kids without intellectual disability, but having the autism diagnosis, about half of medication of some sort. This is a little study. I don't know, it's getting a little dated now, but I really like it because the team that did the research interviewed a whole bunch of different kinds of therapists that would work with individuals with autism. So, or children with autism, I should say. So it wasn't like they just interviewed behavior therapists or speech language. They really kind of went across all those disciplines. And they wanted to see, what people were using, how they perceived evidence-based interventions and the value of them. And it was fairly interesting results. So most providers in their sample used evidence-based focused interventions, but they also use strategies that don't have evidence for them. So it's really a mix. When they asked them about something like a comprehensive treatment program, they were like, oh yeah, that would be really good. They favored that over something without an evidence base. They were endorsed as valuable, as favored, those sorts of things. But here's the interesting thing. Many providers were unsure of the evidence-based for various focused interventions and comprehensive treatment models. So for example, 41% of the sample, 41% of the providers didn't know if cognitive behavioral therapy was evidence-based. And that's a pretty popular one, and it's most certainly evidence-based. So the results suggest that we need to do a better job of educating providers about what is evidence-based so that they can be making good selections as well as good recommendations to their clients. And we also probably need to do a better job of both figuring out and disseminating what are the key components, what are those active ingredients of interventions that make them work. Because what we know about providers out in the community is they're probably going to mix and match across different models and packages and interventions. Like many of them are gonna pull what they like and what they like to do, and hopefully what they know works well. So if we can get a better information about what works well, then they can pull that into their toolbox. Just a couple words about complementary and alternative medicine treatments. So these are more approaches that were developed outside of mainstream Western medicine and are oftentimes used along with conventional medicine. And when they're oftentimes called integrative medicine. So these would be like natural products, mind-body therapies, other biomedical treatments. They're pretty popular in terms of use. And they're oftentimes used because they have sometimes were perceived at least as having less side effects, and sometimes do have less side effects than more conventional therapies. And the interesting thing about it is that families rarely like ask conventional physicians about these approaches, and they also don't generally report that they use them, even if they are. So there's a lot of use of this out there that even like the primary care doctor for a child might not know about. The best place to find information on the evidence for complementary and alternative medicine is this NIH website, the National Center for Complementary and Integrative Health. And there is a section on it specifically for autism spectrum disorder. And they list what they feel very strongly that there is not scientific evidence for. And then in terms of what there is evidence for, like there's pretty good evidence for melatonin, and they do indicate that on the website. And then they also kind of indicate things that have been studied, but again, not enough data to say whether it's working or not. And they also comment on like diets, including ketogenic diets, which are sometimes used with individuals with seizure disorders. Okay, almost here. So I didn't say a whole lot today about treating dangerous behaviors like aggression towards others, self-injury, elopement, because next week's webinar is all about that. So we're going to focus in on interventions and strategies for addressing those dangerous behaviors next time we're together. And now I think we're ready for questions.
Yes, just 1 second. Okay, we do have one question in the chat that it's a question about ABA. She talks about adult autistics are advocating against it, and she's curious if there's any research on longitudinal impacts of ABI on autistic adults.
To my knowledge, and I haven't looked, to be honest, I haven't looked for a number of months, maybe even not since last fall, about the research on this. But to my knowledge, there isn't anything that's looked long-term and looked at trauma symptoms. And I think I kind of alluded to this last week too, is I think this would be very easy to set up in terms of a research study and research design. And I think there are some groups working on this, given the concerns that have been raised by advocates. And I see the kind of the next one there on the question answer kind of is related. So I'll just kind of go on to say, I do think we probably should be thinking about the time and place and type of ABA as well, because with many interventions, the strategies and techniques have changed over time, hopefully for the better. But I think that's really important to define. So for instance, in the original work out of UCLA and the Lovas lab, some of their early work in ABA, there were techniques and strategies that were punishers that people don't use today.
Someone else asks, what is ABA therapy exactly? What kinds of things do they work on?
So you can really target a lot of things with behavioral interventions, because really that's just thinking a lot about using prompting. So setting individuals up to perform a behavior and then reinforcing that behavior or rewarding that behavior so that it's more likely to occur in the future. And so I would say the common areas that like an ABA program would address would be communication skills. Certainly, if there's some dangerous behavior that they want to address, it's a good candidate for ABA. And academic skills, play skills, imitation. You can do things even like fine motor skills and gross motor. Like you can certainly do those using behavioral strategies. But I would say that the bulk of the work is done more in communication and pre-academics and social communication skills.
The next one is, how do I know if a treatment or therapy is evidence-based, and how do I talk to my child's care team about using evidence-based approaches?
Yeah, so that's a great question. So what I would think about is if you can talk to the interventionist about the specific, like if there's like a name for the intervention or for the strategies that they're using, those little focused interventions, then you can start to consult with the websites I provided, or, and you can just start with something simple like the American Academy of Pediatrics, like their recommendations for intervention, or even more simple and relevant to this would be looking at like the Regional Autism Assistance Program's newly diagnosed brochure. It has a list of those interventions as well. And then, yeah, if you find out, the interventions is using something that's not, doesn't have a lot of research behind it, that doesn't mean it's a deal breaker. I mean, you have to think about it a little bit, but I think certainly individually it can still make sense for a child. It's just probably that you're going to want to like track what you're trying to change very carefully, and how you're trying to change it, and kind of check in to make sure what you're doing is actually working.
I think we have time for one more. What is occupational therapy and how does it differ from ABA?
Yeah, good questions. Occupational therapy is a pretty wide and varied category of intervention right now, from working on fine motor skills to play skills to regulation to independence around the home, around the community. So it can mean a lot of different things. So this is where it's probably best to be talking to the OT about specifically what those areas are that you want to focus on, or you want your child to be focusing on in intervention with them. And thinking about how that's going to look in terms of rollout, because oftentimes you'll need to stay with a skill area for a while in order to see progress. So if it's bouncing between, now we're doing motor skills and now we're doing regulation and now we're doing this, like that might not be enough time for the child then to see shifts in those skills.
All right. Well, thank you everyone for joining us today. And thank you, Dr. Pelzel. We will see you next week for the session on treating dangerous behavior.
Thank you.